Okay, thanks very much for this opportunity. Claire, where have you gone? There you go. Thank you so much. The last meeting was exciting enough to want to come back and do the same again. And with John's provocative comments about, well, we're already doing trials without consent. This is going to be a hot day, I think, actually, in here. It's partly attracted so much interest because there's so much going on in the field. So I think we're talking a lot now about Twix trials, but at the same time, there's been an explosion of variety and evolution in all trial designs. And I think one of the most discussed issues around randomized trials in general at the moment is, should they be more pragmatic? There are a bunch of other kinds of trial designs that are evolving at the same time. And so the traditional idea that a randomized trial is almost always this neat, symmetrical, parallel arm structure, that is now no longer true. And the reason for our problems with terminology is partly because of this explosion of new approaches and new thinking around randomized trials. And this is one of the areas in which a lot of the new thinking is happening. I've spent some time with people at PCORI, and it is important to say that, in my mind, this day and the day that follows are all about randomized trials. There's a term, for example, pragmatic studies, that's being used widely in the United States, and that just gently glides over the fact that most of these studies are not randomized. And big data is the alternative to randomization, and so one loses out on many advantages that randomization gives. So we're talking exclusively about prospective randomized trials. So in trying to understand, in this explosion of interest in varied trials, where we are, I think there are three things we can look at in randomized trials. The one is the attributes that they might have. The second is the structures they use to acquire those attributes. And the third is the attitude they have to what is their purpose. And we'll look at those, but we're going to start off with the attitudes one. And Claire's asked me just to talk a little bit about the explanatory and pragmatic trial framework of thinking, which dates back to 1967. This paper, this is an extract from the front page of a 1967 paper in a now a defunct journal called the Journal of Chronic Diseases, which became the Journal of Clinical Epidemiology. And Schwartz and Lelouch, who were two French statisticians, and their translator but colleague, a British statistician who worked at the London School of Hygiene just down the road, Michael Healy, who was my statistics tutor when I was at the London School of Hygiene. The three of them wrote this paper, actually, and their basic point of view is that we think, and this was 1967, of trials as a single entity, but in fact, trials are inadequately formulated because of that assumption. In fact, there are two kinds of trials, two attitudes to trials, and people are not aware of the fact that there are two attitudes, and so they assume a default. And they then went on to describe what these two attitudes are. Now, this is moving towards work from Dave Sackett, who was probably the first person to take this understanding of pragmatic and explanatory trials, and he specifically tried to turn it into an understanding that would be relevant to clinicians thinking about trials. So Dave, drawing from the Schwartz and Lelouch paper and a book that they wrote, which was an expansion of that paper, talked about trials that are pragmatic, and he was still thinking about it in a fairly dichotomous fashion. But he thought of trials which are pragmatic, and he used Schwartz and Lelouch's language, are those which are aimed at informing a decision, a clinical decision in this instance, but could just as well be a policy decision, service delivery decision, educational policy decision, whatever. And the other alternative to that, seen as a bit dichotomous, was that that there was another set of trials that were aimed at understanding causal relationships. So the first is informing a very concrete decision. The second is exploring an underlying mechanism of action. And those two, even though they were both randomized trials and the idea was merged, they are very different. The first is a community-oriented answer, which tells us whether an intervention offered by a range of people who provide that intervention, because in the real world it is a range who will provide it, to patients who may well not take that intervention. Dave Sackett had done a lot of work on adherence. Whether, having done that, it causes an acceptably lower risk of harm and does more good than harm. So he complicated the meaning of that, but clarified, I think, the meaning of the explanatory trials, that these are biologically or mechanism-oriented trials, which tells, and the way they achieve that mechanistic understanding is by tightly controlling the conditions of the trial, several conditions. When a drug prescribed by those best able to use it is taken faithfully by patients, and when that drug exhibits all of its done, then does it do more good than harm. So the 10 things that he pulled out from this were, number one is to clarify the nature of that decision, and he then puts this framing on it. Is this treatment working when it's provided under idealized circumstances versus usual circumstances? The narrowing comes in starting in the second one, when patients were very strictly selected, limited to high risk, often highly responsive and highly compliant patients, versus whoever might get that treatment once the treatment is demonstrated to be effective and unleashed in the wild. So when that treatment is available in the real world, all comers who would get that treatment, well, that's who you would be thinking of including in a pragmatic trial. And similarly, on some of the analyses, the exclusions and inclusions from analysis, you could exclude patients, for example, if they didn't take the drug or if they were found to be ineligible at entry. You would usually include them in the pragmatic trials, and so on. The treatment given by the best hands, intensity of follow-up high, patient compliance closely monitored and maybe strategies for improving it, clinician adherence closely monitored, and so on. The events of interest narrowly focused on biological events, often measured using upstream measures, many of them biochemical or physiological. Duration of follow-up, well, you're looking for that event and you lose interest soon after. Eligibility of analyses, quite restricted approaches, very tightly controlled, and that contrasts a lot with the pragmatic trial. In cartoon fashion, and I've lost the attribution for this very nice cartoon, but thanks to whoever did it. The explanatory trials, you have the team outnumbering the patient or the participant. Enormous emphasis not on the patient and their usual kind of care, but on the measurement of the outcomes and of the covariates that you might be collecting. And it's not a very specialized setting, but note that examination bed, great contrast with the usual care setting on the right, a much more heterogeneous group of patients, gender, race, many other things, age particularly. Usual care, the trial person is also the clinician and is responsible for the care of that patient. So trials which are very embedded in the usual flow of care, and a very different ratio of trial participants to trial managers and coordinators. So very few extra resources added. So that was the cartoon version. This is a version which was developed by Dr. Kirsty Ludon, who's a PhD student with Sean Treweek and I, and who tried to turn the Sackett ideas and the non-quantified ideas that were first appeared in the Precy paper into a more quantifiable and more consistent and coherent picture. This paper was published last year in the British Medical Journal, and it's been rapidly and quite widely cited. And there are nine axes. And so what Kirsty's work does is it suggests that there is not only a continuum between pragmatism and explanatoriness, if there is such a term, but there are 9 axes on which that continuum is based. And these axes are largely independent. These 9 things can be independently varied in the conduct of a trial. And the issues are: who is selected to participate in that trial, narrow or broad? Are those participants recruited in the usual flow of care, or is a special and external effort made to recruit them? Is the setting being done in something like usual care? Are extra resources required to run the trial, and are those going to influence unintentionally the way in which care is provided, thus creating an additional covert intervention? is the flexibility with which care is delivered left in the hands of those who deliver that care? In other words, is it going to be just like it is in usual clinical care, where there's an enormous amount of autonomy on the part of the clinician as they try and turn whatever evidence they're using into something which matches the needs and values of that patient? So is there flexibility? Is there flexibility in adherence? There's just as much variation on the part of participants in studies as to whether or not they take and how they use and what else they use with the intervention that's been that they've been randomized to. So these characteristics continue, and so we've got how closely are participants followed up. And again, the implicit thing is, are they followed up more closely than they would be in usual care were this intervention to be shown to be effective and then widely distributed in the wild, in the real world? So that's the implicit comparator for all of these things. And then lastly, the primary analysis: to what extent are all of the patients who were exposed to the intervention included in the final evaluation of its effects and goods and harms? So these are the 9 criteria that have become embedded in PRACY and that exemplify the 9 things that put a trial on the spectrum between explanatory and pragmatic, between a trial aimed at supporting decision-making in the real world and a trial aimed at clarifying and elucidating a causal relationship or a mechanism of action. I thought I'd give 2 examples of these trials, very old ones, just to show how far back this goes and how far back these trials have diverged without us noticing. This is from the 80s, well before there was any broad discussion of randomized trials being pragmatic or not. And in the same year, just 4 months later, this trial was published on the same intervention. And as you can see, the shape of those circles illustrates the degree of pragmaticness on each of the 9 axes. The further out you go, the more pragmatic the trial is on those 9 criteria that I mentioned. This trial, which was the GC trial, I don't speak Italian, but it was the Italian trial on streptokinase in myocardial infarction from the 80s, was extremely pragmatic. If we start at the top there with eligibility, essentially if you came into the hospital, any hospital in Italy with a myocardial infarction, within 12 hours of your reported onset of pain, you were eligible for the trial. That was it, unless you were known to be unable to take streptokinase. The second recruitment issue, patients were recruited in 90% of the critical care units and hospitals that treat myocardial infarction in Italy provided patients for this trial. 90% of the available places in an entire country where you could get this treatment put patients into the trial. Of the patients who were eligible for the trial on that very simple criterion, some 60% of the eligible patients actually were recruited in the trial, and the sample size here is 12,000. So this was one of the first large trials and amazingly simple and very well integrated in the flow of care. So the setting was the usual care setting. The organization, 90% of the hospitals, hundreds of sites, nothing was added to each site. Flexibility of care, no intervention in how else the clinical care was provided. Nothing on adherence, not necessary, of course, in this case. It was an intravenous infusion. Follow-up, unchanged from usual care. Primary outcome, mortality at 21 days. Easy to measure. No need for any extra follow-up in between. And the primary analysis used everybody. And that contrasts with a study that was published and just to say, this study was extremely influential. It was one of the first and most influential studies on streptokinase. This study was the ISAM study, the International Streptokinase Against Mortality and Myocardial Infarction, I think, study. Predominantly a North American, US study, but also with sites in Germany and elsewhere. I think there might have been a site in the UK. Eligibility, not quite as good, but we've rated it fairly high. It excluded people over 75, who include a large number of people who come in with a myocardial infarction. Recruitment within the flow of care, but with an extra team to do that recruitment. The setting, well, it turned out that the settings that were used were specialist cardiovascular-oriented critical care units, so quite specialized, but we've been fairly generous. Organization, again, there was people who were providing primarily trial support, unlikely to have changed the clinical care that was provided. So no co-intervention there. Very little flexibility. This was it was a placebo-controlled trial, unlike the GC trial, which had no placebos and no blinding. Flexibility on patient adherence, well, obviously it's an intravenous infusion. It's provided in emergent care, and so there's not really an issue there. Patients were extraordinarily closely followed up and investigated to the eyeballs. Every imaginable test available in the 80s was done. And the primary outcome, although the primary outcome was mortality, when you look at the final publication in the New England Journal of Mortality, the non-significant primary outcome, it wasn't significant, there were only 1,700 patients. The non-significant primary outcome got a few lines, and then what really got coverage in the discussion and the results section was a secondary outcome and possibly even a secondary analysis which looked at the area under the curve on something else. I got quite lost in it. And then a subsample of not randomly sampled, not systematically sampled, just who they could get. They looked at something else in just the intervention group. So there was a really less focused outcome measure. And so the primary analysis, as a result, excluded quite a significant number of people. So you can see that at the same time, well before this thinking on pragmatic trials was in place, people were doing very different kinds of studies of the same intervention at the same time in what you would think of as similarly qualified institutes. And so I think what this shows is that the Schwartz and Lelouch idea is that we're doing unconsciously two different kinds of trials is real. There can be very big differences between what could otherwise be identical trials. And so it's this that I want to try and think about in relation to the Twix design. Just to finish with what Schwartz and Lelouch said, although the paper presented itself as simply a description of two attitudes to trials, and we've later tried to advance that by making it more of a measurable, a metric around it, they ended by saying, really, we should be doing more pragmatic trials. We've adopted the explanatory approach without even being aware that there is an alternative, and often the pragmatic approach would have been more justifiable. So if you hold that in mind, this notion that there are two kinds of trials connected on a multi-axial spectrum, and that multi-axial spectrum is really influenced by how you design the trial, the specific elements of the trial, then I'd like to just try and connect it back to the Twix by looking at three things for trials. One is the attributes, the second is the structure, and the third is the attitudes. We've met the attitude, it's the pragmatic or explanatory attitude. And I'm sure you've seen these terms previously. These are what I would think of as the synonyms for pragmatic trials. As far as I can tell, the efficacy and effectiveness concept developed independently. The mechanistic and practical trial concept developed in reaction to the pragmatic and explanatory trial. But I would say that they still form two basic attitudes towards randomized trials. Trials which are essentially conducted under real-world conditions, a lot of attention paid to not distorting the delivery of care. And the goal of that is to produce information which directly informs trials versus trials which are conducted under quite idealized conditions with extra resources where what's of interest is the mechanism of action, often confirming or denying a specific hypothesis. So that's the attitudes to trials. But I think there are also many, many trial designs. I mean, this is part of the explosion that we're seeing of trial designs. I got this list of trial designs by just looking at the last 500 mentions of the word randomized trial in PubMed and just seeing what kinds of trials there were. You can see that there's a bunch, but I've classified them according to what attributes I think that particular design is attempting to emphasize. So the factorial trials, and I think platform and adaptive trials are about different kinds of efficiency. So for example, the factorial trials, you can squeeze in multiple interventions with some provisos to a single trial. The sequential trials are efficient because they stop recruiting patients instantly. You know that instantly that there is sufficient patients to get a difference. The large simple trials are about efficiency by speeding or easing recruitment. The N of 1 trials are structured around something completely different. So a very different attribute is being developed with the N of 1 trials. It's to individualize the treatment effect estimate, which you can't individualize that estimate from a large trial of any kind, from a usual trial. You get an average effect and maybe subgroup analyses, but within the N of 1 trial, you're randomizing time periods on a single patient, and so that allows you to individualize the treatment effect. Other attributes that people have emphasized as the number of trial designs has expanded, you can test an alternative statistical hypothesis, not superiority, but equivalence. You can evaluate interventions aimed at groups. You can integrate randomized trials with the flow of care. And of course, that's where TWIX trials come in. And it's not yet clear precisely what the difference is between TWIX trials and registry trials, but I'm making a shot that the TWIX trials have a much clearer definition of the cohort and a much more explicit intent to follow them up. The registry trials tend to be registries of people who receive a treatment or have a disease. It's a little looser and less attention is paid to following them all up. There's a bit of an open-ended question about why we make registries. So I think nevertheless, the attribute that has led to the development of these trials is in order to try and integrate the trial within the flow of care. So then we can look at these trials also in another way. We can say, well, what is it that structurally is different about these different trials? And so I think the first set of structures that you can see in trials is a set of structures around how we organize treatments. Factorial trials, platform trials, registry trials, all of these use the way in which we provide treatment differently. They restructure treatment. There's a bunch of trials that do that change the way in which we address the comparator. So crossover trials, for example, maximize the sample size by going back and forth and changing the status of patients. We have other trials which are different in the unit of allocation. So N of 1 trials allocate time. Cluster trials allocate interventions in groups. And finally, we have a bunch of trials that play with the notion of sample size and how we calculate it. And you can see that the registry trials are really quite doing a heterogeneous set of things. They're potentially playing with the treatments that we get. They're potentially changing the nature of the comparator from being randomized to being those not randomly selected for, but who are members of the cohort. And they're also playing with the notion of sample size by establishing a very large eligible pool and then pulling from it. So the structures of these different kind of randomized trials is different. And so I think that we could start connecting these three concepts by realizing that the attributes of a trial can apply to any attitude. In other words, you could design a trial which increased sample size by making it large and simple, but that doesn't mean you've necessarily made it pragmatic. So you can have a large, simple trial which is pragmatic, but you can also have one which is explanatory. And the same is true of structures. It seems to me that the issue of attitude is independent from the issue of structure or attribute. And so what that implies is that a TWIX trial is also potentially somewhere on that axis and on these 9 axes, and you can move it where you want it to be moved. So a TWIX trial, although the original justification for it is to integrate it into the flow of care, and although the motivation for individuals who've designed it, like Claire, is to make a difference in real-world treatment, it doesn't necessarily mean that every TWIX trial has to be designed to be very pragmatic. Because these are independent issues, we could just as well design a TWIX trial to be rather explanatory in nature. We may not want to. We may want to sometimes. Sometimes we may want to have multiple trials or multiple arms and design them in such a way that one produces a much more explanatory answer than another, much more pragmatic answer than another. And so it looks like I duplicated my slide. So that's the bottom line. I think that we have a number of independent classifications of how trials are organized. The attitudinal classification applies equally to most trial designs, whether we think about the attributes or whether we think about the structures. And I believe that to be true for Twixt trials, that you could have a pragmatic or an explanatory Twixt trials. Thank you.
Within your axes that you've got, they've got like 5 points. Is there some description in the article of how you move up between those?
Yes, there is. There is in quite a lot of detail, and with some case examples. Yep.
I wonder if you had any comments on the sort of political acceptability of pragmatic versus explanatory trials.
I mean, it depends which polity you're talking about. So I think there is a change. There's an increasing tendency to favor pragmatic trials, at least rhetorically. So PCORI in the United States has been moving in that direction explicitly. Even the NIH and its big collaboratory on trials has tried very hard to promote a more pragmatic approach to the design of trials so that they become more useful. The whole comparative effectiveness research mission, which preceded and created PCORI, has done the same. So I think there really is a groundswell towards saying we've had 400,000 randomized trials, 300 and something thousand of them have really been indirect at best contributors to decisions for patient care. And so that mechanism, the mechanistic or explanatory trials, the distance between a trial finding and its relevance to a patient in front of you is so long and so dependent on knowing in depth about that mechanism. And we often know so little about mechanisms that is no longer acceptable. We're not getting the answers we need, and so we need to invest in a different kind of trial. And so I think there is a real push towards designing trials which can be directly applied to patient and community care.
Thank you, Merrick. That was a really interesting talk. Do you just want to explain what PCORI is?
PCORI, sorry, the patient. Sorry, it's a large, as only the Americans could do. It's umpteen $1 billion of funding that's been dumped into an institute called the Patient-Centered Outcome Research Initiative, not institute, initiative. And it's quasi-non-governmental. It's independent from all governmental agencies. And its goal is to fund large amounts of research which will inform patient care. And they take the words patient-centeredness very seriously. So patients are engaged in the design of all of these PCORI-funded trials from the moment of conception of the question right the way through to data collection, trial design, choice of outcomes. So they take patient-centeredness very seriously. Go ahead.
You know, the real-world patient decision-making aspect that people talk about with pragmatic trials, I think this is my impression, but I would like your comment. It seems to me that makes sense if the clinician is only interested in average community effects. And because the pragmatic design really gives you answer for averaged across a heterogeneous group in practice. So if you're a health system administrator allocating resources, I think that makes a lot of sense. But we often say things like, it helps individual physicians make real-world decisions for individual patients. Well, it's not so true. It's true if you practice based on average community effects. And I think that's a little bit, because the logic of it is such that that's what it implies. And I'm wondering if that's...
So do you think that explanatory trials provide you with individual patient information that is usable?
Well, for a subgroup.
But a subgroup is just a smaller group. So what you've got is an average of a differently defined
group.
group.
The point I'm making is this. Patients, clinicians who push the pragmatic trial will say things like, well, you know, if I had that pristine, moderately depressed patient, I know what to do. But what if that person has alcoholism too? And they would say, that's why we need pragmatic trials. Well, that's not true. You have to pre-design the pragmatic trial to answer that question also, to have that individualized decision-making information. And I'm just pointing out, I think that this is often sold as, individual clinicians benefit. It is in a sense, but it's not so specific as people often infer. Do you see what I'm saying?
I understand exactly. I think it's a long discussion. I'm not sure whether...
I just wanted to respond to it very quickly.
Go ahead.
Because
We can discuss it over tea.
yeah, I mean, the individualizing to patients depending, in cancer, it's all about stage and grade. And most of the trials we do in cancer are pragmatic. You're randomized to chemo or best supportive care. And the individualization issue has got nothing to do with the design. It's to do with the analysis. And my group and several other groups in the US, what we do is we try to avoid subgroup analysis, but do prediction modeling. And then you can actually go online in cancer and type in the characteristics of the patient and find out the reduction in recurrence risk based on their individual characteristics, rather than just taking the group average.
And I would just say one other thing, which is if you design an explanatory trial which narrows the types of patients down, you have two choices. Most of the patients you will then try and extrapolate the results who don't fit that narrow group. They're not in the right age group. So that what the pragmatic trial does in compensation is it tries to increase the relevance of that average. But it's dependent on the attribution to an individual patient of an average effect is always going to be beyond us. There is no way, there is no data big enough for us ever to do that. And so I think we have to understand this and see what we can do within the limitations.
We're